Hello, everyone. Good morning. So yeah, I have no disclosures. So Merichu covered very wonderfully about the symptomatology, but just let me reiterate that the classic claudication that we talk about, exertional leg pain, it only occurs in about 10 to 30% of patients. And like she mentioned, almost up to 50% of the patients can be asymptomatic and can present with atypical leg pain. And even among all of these population, at least 3 to 5% of these patients will progress to critical limb ischemia. Okay. So your history taking, your key points definitely should focus on the classic claudication symptoms. Ask them about, how much they can walk, when does the pain occur, if it occurs exactly when they start walking, or if it occurs when they actually have been walking for a certain time, and what makes it go away. So usually with PAD patients, the pain will go away when they are at rest, and not just at rest, but actually standing and stationary, because that's when the gravity leads to increased blood flow in the lower extremities. And yes, aortoiliac disease can lead to pain in thigh, buttock, and erectile dysfunction. And fempop disease will usually cause symptoms in calf muscle. So it's always the symptoms occur one level below the affected artery. And okay. So certain things that can be confused with PAD and certain key points that can help you differentiate. So spinal stenosis can also present with like exertional, when they start walking, they will have pain that starts from their back, goes to their legs. That's usually how the curvature of the spine changes. So they will also report that when they sit down, their pain goes away. So, but the PAD patients will typically say that they have to keep standing and be stationary. That's what relieves the pain. So arthritis is another differential. You see it very commonly. Patients will joint fatigue, joint pains. Neuropathy pain is also can wake up in the middle of the patients wake up with a burning pain in the middle of night, similar to PAD patients. But usually PAD patients will sit and they will dangle their feet, and that's what their symptoms will resolve. But that won't happen with neuropathic pain. Okay, so in certain times, like because PAD patients tend to keep their legs in dependent position, so they do tend to develop some edema. So that can be confused with venous disease at times. So just be mindful of that. And of course, your history taking should also involve, finding out about all the risk factors that can contribute to the disease. Okay, so physical exam, the inspection, on inspection when skin is ischemic, it's dry, shiny, it's hairless, and the nails will be hypertrophic and brittle nails. Your examination, most important part of it is palpation and auscultation of all of your peripheral vascular beds, including femoral pulses, popliteal pulses, dorsalis pedis, posterior tibial, all the peripheral pulses. Assess the skin temperature. So PAD patients will have the colder skin in their lower extremities mostly. Okay, and just one thing I want to mention is that abdominal bruit is a very significant predictor of renal artery stenosis. So, PAD patients tend to have this something called dependent rubor. You will see that some of these patients will have this red skin, and it can be very much confused with something like cellulitis. But just one thing that you can do to differentiate is if you raise their legs, they will develop pallor. But in cellulitis, that won't be the case. And usually, temperature-wise also, cellulitic limbs or cellulitic skin will be more warm compared to a PAD skin. Okay? So, and just the ischemic ulcers and gangrene is the CLI form of PAD, another part of the spectrum. So ischemic ulcer, they occur on the lateral malleolus or the tip of the toes between digits. So when you examine these patients, make sure you look at their between digits, because they do tend to develop these small ulcers there. Okay, or any focal pressure areas, and they tend to be punched out, dry. There won't be any bleeding because it's essentially the lack of blood flow there. Okay, and also have to assess the skin around it if it looks ischemic. And just keep in mind that patients with edematous legs, they can have mixed ulcers. They can have mixed venous and arterial ulcers. Okay. So, the role of non-invasive testing in PADs, it's very important. And because so many of these patients are asymptomatic and they have almost similar prognosis as the symptomatic patients, it's very important. That's where the screening comes into play. So, we remember to screen everyone above 70 years of age, more than 50 years with a history of diabetes, or more than 50 years with a history of smoking, essentially all the risk factors, or even in younger patients, if they have risk factors like obesity or high cholesterol. Okay. So our ankle brachial index, it's one of the first line non-invasive tests that we order to diagnose. It's essentially the ratio of your blood pressure of your ankle to the highest blood pressure of your arm. So if you see on this example, on the right side, the brachial pressure is 122, and your ankle pressure is 127. So your ABI is on the left and right, as you see, is 0.8 and 1.04. And in the ankle pressure, it measures pressures of both dorsalis pedis and posterior tibialis. So you have to take the highest of that among both of those. Okay, so diagnostic performance of ABI to detect PAD with more than 50% stenosis is up to 70% sensitive and 80% specific. The normal value is 1 to 1.3, borderline 0.9 to 1, 0.7 to 0.9 is mild, and 0.4 to 0.7 moderate, and less than 0.4 ABI is consistent with severe PAD. So in certain patients, when your arteries become calcified, they can become non-compressible, or they can lead to very high falsely elevated ABIs. So more than 1.3 ABI is actually indicative of stiffened calcified arteries. In those patients, instead of the ankle pressure, you measure toe brachial index instead of the ABI. So the toe brachial index, more than 0.7 is normal and less than 0.4 is severe. Okay. So let's say if you have a normal ABI, but you're still suspicious because, just based on their symptoms, that you're thinking that no, they could still have it. So in those patients, you do exercise ABI. So a drop of ABI more than 20% with exercise, or a drop of ankle pressure more than 30 mmHg is usually is diagnostic. Okay. So on the right side of the screen is the normal response to exercise that should occur with dorsalis pedis and posterior tibial. You see at rest and at exercise at 1 minute, the pressure goes up. But in patients with PAD, you see the DP and PT pressure will go down while your brachial pressure is still going up. Okay, so PVR waveforms is something you get along when you get these ABIs testing. They do PVR, they give you PVR waveforms as well. So a normal PVR waveform, just remember the morphology of it. It has a very brisk systolic uptake, upslope, very sharp peak and a sharp downslope, and a very distinct dichrotic notch during the diastole, or a very clear inflection point. And as your PAD gets worsened, your PVR waveform will start to lower in amplitude. It will have a rounded peak. But the first thing that will happen is the PVR waveform will lose its inflection point, or the dichrotic notch, as you see in A. And it will, as the disease gets severe, it gets very lower in amplitude and very rounded peak. So as you see, so the PVR wave, so this gives you the pressures and the PVR waveforms, and that's how you usually get an ABI report. So as you see on the thigh, sorry, one second. Okay, so you see on the upper thigh cuff, it says NC. That means that it's non-compressible. So you can't really know what the pressure is there. In that situation, you can actually look at the waveforms. Your waveforms look pretty much normal. So that's where the waveforms come into play. And if you can't get a pressure, then you can rely on the waveforms to see if there's disease there. Okay, segmental pressure is taken at 4 levels in your legs: upper thigh, lower thigh, and calf and ankle. Okay, as you go down the leg, there should not be more than 20 to 30 mmHg variation. Okay, if there is more than that, that's indicative of disease. Okay, so this essentially is like a normal waveforms and your normal pressure. You see your upper thigh, lower thigh is 158, 158, then calf is 138 and ankle is 150. So and ABIs are 1.23 and 1.2. Your waveforms look great. So this is essentially a normal segmental pressure and PVR waveform exam. So on this, if you see on the right side of screen, you see the first waveform on the right side, which is high thigh pressure and waveform. You see how the waveforms are very decreased in amplitude. They don't have the dichrotic notch, and they have a very rounded peak, and their amplitude is only 9 mm. So it suggests that there's disease above this level. So that would indicate an iliac disease. And as you go down the levels in from high thigh to mid thigh, your waveform maintain their morphology. So that's an indication that you probably don't have disease there, and it's just the iliac disease. On the other side of the screen, you're seeing the normal waveforms, and they maintain their morphology, and so that's like a normal exam. So this would suggest unilateral right side iliac disease. Okay. So on the other hand, in this example, if you see on the right side of the screen, you're seeing the high thigh waveform look great. Their blood pressures are okay. And as you compare the high thigh waveform to your calf waveform, there is a significant here. So there's a significant change in morphology. So you compare high thigh to calf, and you compare low thigh to your ankle. So that will indicate from change of this waveform from high thigh to low to calf will indicate that there is a disease, a FEMPOP disease somewhere in this segment. If there is a change from lower thigh to ankle, which it's there, that will indicate a tibial disease. So this would be an example of like a multi-level FEMPOP disease. On the other side, you're seeing that the waveform in the high thigh itself is it's not normal. It looks like severe PAD waveform, and that would indicate that there's disease above this level. So this would be an example of somebody who has multi-level FEMPOP disease on the right side and iliac disease on the left side. Okay. All right, so ultrasound Doppler is another excellent modality of both screening and diagnosis of PAD. And if your ABI is usually abnormal, then that's the next test that you order. And the great thing about it is that it not only provides you anatomic and morphological evaluation of the arteries, but also the physiologic information as well. So the ultrasound waveforms, these are just diagrams, but a normal ultrasound waveform in a normal lower extremity artery will be triphasic. It will have a sharp upstroke, a sharp downslope, and they will be flow in diastole, and then a third wave above the baseline. As you get PAD gets worse, there is usually no flow below the baseline. So it's essentially termed as a biphasic waveform. And as you get worse, it gets monophasic. Okay. So peak systolic velocity ratio is something that you look at in an ultrasound. If you're expecting that lower femoral artery has disease, then you will compare the velocity at that segment to the segment just immediately before that. And that ratio, if it's more than 2.5, is usually significant for at least more than 50% stenosis. And it's very helpful in surveillance after SFA interventions for surveillance of patients. And usually if there's 100% occlusion, then there will be no flow. Okay. Transcutaneous oxygen measurement can also be looked at for PAD assessment. It's essentially the absolute value of oxygen tension at limb. A normal value at the foot is 60 mmHg, and values lower than 40 mmHg are associated with poor wound healing, and less than 20 mmHg is associated with CLI. CTA is a great non-invasive alternative to angiography for morphologic assessment. It is very highly sensitive and specific for details, but again, it does not provide any hemodynamic assessment, and it's definitely problematic in renal insufficiency patients. MRA is superior to CTA and duplex sonography for detecting more than 50% stenosis. For tibial vessels, probably MRA is the best test. But again, it has several limitations. It's prolonged acquisition times, limited availability, cost, and in patients with renal insufficiency, there's always risk of nephrogenic systemic fibrosis. So take-home points just about the non-invasive and most important point is that you have to remember that PAD can present as just atypical symptoms or even just asymptomatic. So it's mostly about the entire patient and looking at their risk factors and be aggressive with the screening. Lower ABI values less than 0.9 is usually diagnostic of PAD. Combining ultrasound Doppler with ABI response and PVR waveforms, it increases your diagnostic accuracy. And segmental pressure changes and TBI, looking at the toe brachial index values in non-compressible vessels can be beneficial. Ultrasound is the first-line diagnostic test for post-revascularization surveillance, and PSVR ratio of more than 2.5 is diagnostic of more than 50% stenosis. So thank you. If you guys have any questions, or okay. Thank you.